Hi, my name's Ash.
And I'm Callie.
And welcome to Paved with Gold, the Eating Disorder Recovery Podcast. I would like to acknowledge the traditional landowners on which Callie and I are recording and extend the same respect to the traditional custodians of the lands from which you are all listening. Today is a very important episode, and I know we always say that it's like long overdue, but in this case, we have been talking about having an episode like this for a while, and it's also been heavily requested. So it's also something that we definitely could not talk about with just the two of us. In fact, it would actually be quite harmful for us to do so.
I would, not dream of it.
No. So today we are talking about eating disorders in transgender and gender diverse folk. And we are extremely lucky to be joined by an incredible guest to talk about this very under-researched and undertreated issue. So our guest today is a sexologist, youth worker, and amazing researcher who is currently completing their PhD, which focuses on improving eating disorder treatment for trans and gender diverse folk. They are a research affiliate at the Inside Out Institute for Eating Disorders, where they are involved in a large study of the body image and eating disorder behaviours of LGBTQIA+ people, which is called the Included Study. So we stand already. Mm-hmm. It is a great honour to welcome Kai Schweizer to the pod. Hello.
Hello.
Hello. Thank you for having me.
Oh, it is our pleasure.
Yeah, thank you so much. When Ash was sort of just going over everything about you the other day, and I was just like, yes, amazing, incredible, perfect. Cannot wait.
So the first thing we always do on this podcast is to get you to tell us a little bit about your background. Can you tell us a little bit about your research and what drew you to this space?
Yeah, sure. It's been, a very, very long process of getting to this point, I think. And it's something I've been interested in for, despite being reasonably young, over half my life now. Just strange to say. So I guess as a teen, I was surrounded by many people with eating disorders, and someone very close to me passed away when I was younger from complications related to an eating disorder. So it was something that was present in my life from when I was 12 or so, and was something I was experiencing myself as a teen and continue to have as part of my life now as lived experience of an eating disorder, although the kind of eating disorder has certainly shifted from as a younger person, it was anorexia nervosa, and now as an adult, I have an ongoing diagnosis of ARFID, which for folks who don't know is avoidant restrictive food intake disorder, which is kind of sits on a strange place in terms of whether it's an eating disorder or not. People don't necessarily agree on that. And yeah, as I got older, I sort of moved into a professional life where this just kept popping up as I started discovering myself and my gender in the trans community. I kept seeing it as well, just in my social life, that it seemed to be just so common to have either disordered eating behaviors or eating disorders that it was almost normal. We sort of didn't see it as a problem. But yeah, just in my professional work, when I was doing more case management and direct work with young people, all the trans young people I was working with seemed to have some kind of concerns around eating, exercise, body image, that it almost seemed close to 100% of people. And yeah, it just kind of built up to a point where I was like, we can't keep ignoring this. We were talking a lot in research, in community spaces about the high rates of suicide attempts, which were data was starting to come out then that it was about 50% of people. But it seemed like the rates of eating disorders, disordered eating were just so high, but there was no conversations about that. And so it sort of started with giving a few little presentations about the topic that were not super evidence-based because there was no evidence. It was just trying to raise awareness of the fact that there did seem to be an issue. And that launched into having conversations with the Children's Hospital here in my state about the fact that they were indeed seeing this gigantic spike in the presentations to the eating disorder ward of transgender diverse young people. And that kind of culminated in eventually my master's project as part of my Master of Sexology. I ended up looking at the treatment experiences of Australian transgender diverse people. And that really highlighted the fact that, gosh, it's really bad. The treatment that people are experiencing here is not so good. And now I'm finally kind of reaching the point where I am starting to publish and working on my PhD, which is going to be a massive undertaking of a bunch of studies, all sort of focused on understanding the intersection of gender diversity and eating and exercise. And sort of the core intention is the end output, the big end output of my PhD is going to be a set of guidelines on best practice in treating eating disorders in trans and diverse people, which will be pretty multidisciplinary, probably social work, psychology, nursing, psychiatry, dietitian focus, peer support workers, sort of hopefully, yeah, something that can actually guide the work to fill that gap right now where most people in the field just aren't sure what to do and how to be helpful.
Mm.
Oh, this is
Yeah.
I'm trying to like calm down because I'm like so excited to talk to you because this is just the gap that there is in the way that we treat gender diverse folk is it's not a gap, it's a chasm or a canyon of where they're just people just getting completely lost in the system and causing more harm than actual help.
Well,
I think a lot of the time.
It's madness to me that this is like up and coming. Like, why hasn't this been done already? Like, it's kind of like, which it's incredible it's being done now, because I just think of a few of my clients and their experiences within the hospital system when they're needing to be in the system, and it's almost like this system that's like fumbling of like, well, we don't know what to do with them, and it's like, oh my gosh, like that is just so dangerous. So that is just incredible. I was wondering if we could talk a little bit about what the prevalence of eating disorders in trans and gender diverse folk might be, because I feel like that's a big question that's always asked, and not many people can actually answer that because we don't have the data there.
Yes, we have some data that's starting to come out now in the last couple of years. It varies, the prevalence rate varies to some extent from study to study, but almost every study that's been done finds that the prevalence of disordered eating and or eating disorders is just drastically higher than in the general cisgender population. The most recent study, the sort of preliminary data from a while back of the included study that I've been involved in, it was the last time that I analyzed the data was about August last year, so not up to date current stats, but off the top of my head, the numbers we had at the time was 2,400 trans people, of which 99.59% had disordered eating behaviors in the past 3 months. So what I said before, that it felt like it was almost all people when I was in community, it was almost all people in the community.
That's basically everyone.
Essentially, almost every single trans person is experiencing some level of disordered eating behaviors based upon our findings there. Below that, sort of into the clinical severity range, we get that about 35% are scoring above the clinical cutoff on the EDEQS, which is Eating Disorder Examination Questionnaire short form, which indicates a likely eating disorder diagnosis. But about 13% of our participants had a current diagnosis of an eating disorder, which, if we kind of do the math there, it's 22% gap. So more than 1 in 5 of the people who had a suspected likely eating disorder based on their scores had no idea from a clinical setting that they had it.
Wow.
Just huge.
It's
the gap is also huge just generally between people who are needing support and treatment and diagnosis and who are getting it, but it's an even bigger chasm in the trans community. And I got curious in preparation for this and did this sort of a bit of a quick extrapolation of the stats using the ABS data that we have about census populations, and compared that to the estimations that we have of what percent of the population is trans, and the data that came from the included study. And that, if you put all that together and do the math, then it means that about 440,757 So almost 441,000 trans people in Australia have an eating disorder. But that's the people who are broadly have one, not the people who would actually have been diagnosed. So huge numbers, realistically. And you don't see
Massive.
that
Huge.
you're walking into a clinical setting. You would think that would be a very substantial portion of the people accessing care, but it's not. This
Yeah.
gigantic.
Yeah.
Yeah, I guess eating disorders are pretty broad, and there's a lot of diagnoses under that. So I'm happy to talk about sort of which ones are most common and how that compares to what we see in the general
Yeah,
population.
that would be
Yeah.
amazing. Absolutely.
Yeah.
And that's all my prevalence nerding out after that.
No, please do, because I could listen to this all day. So
Yeah,
please.
nerd out, please.
Yeah, absolutely.
You're in
So-
good company.
Generally, we think of like anorexia and bulimia as being the most common eating disorders.
Mhm.
That's not necessarily true in the general population either, but it's the people accessing treatment and needing care for the severity of their eating disorder do tend to be people with anorexia or bulimia. In the trans population, the most common eating disorder is anorexia nervosa. And then after that, ARFID, avoidant restrictive food intake disorder, is almost as common as anorexia nervosa. Binge
Wow.
eating
Wow,
disorder
okay.
kind of fits underneath of that. And then OSFED, and then bulimia tends to be down the bottom of that in terms of how common we see them. About 21.47% of the people who have an eating disorder who are trans have anorexia.
Yeah.
But
Wow.
despite that, if we compare that to the prevalence rates of eating disorders that we see in the general population of cis people, bulimia is significantly higher odds compared to cis people. So it's about 6 times more likely that a trans person will have bulimia than a cis person, and about 4 times as likely that they'll have anorexia compared to a cis person.
Wow.
Wow.
So if we were comparing people with an eating disorder who are trans and who are cis,
Yeah.
the odds of which diagnosis it will be are higher based upon that. So binge eating disorder also about 3.5 times more likely as well. So that might be to do with the ADHD co-occurrence overlap as well.
Yeah, I was going to ask
Yeah.
about that, to be honest, because I feel like, and I guess talking about ARFID as well, and I know there's a really higher prevalence of neurodivergency within ARFID as well. So I was going to ask about that link there as well, if we can.
Yeah, absolutely. It's always something complicated to discuss because of the way that the high rates of neurodivergence in trans people are being weaponized by anti-trans rhetoric to sort of say that trans people don't exist. It's sort of a symptom of autism.
Oh
It's
my God.
or that a person who is trans is an autistic person who is easily influenced or vulnerable to social pressures. But it is also a truth that the rates of neurodivergence, particularly autism and ADHD in trans people, are much higher. I think in some of the studies I've been doing and looking at recently, over 80% of people who identify as trans or gender diverse consider themselves to be neurodivergent. About 70 something percent consider themselves autistic.
Wow.
And
Yeah.
yeah, it's so high that we often joke about the overlap being a circle rather than the Venn diagram being a proper Venn diagram.
Yeah.
But the rates of diagnosis are very, very low. This is why when we do research in this space, we ask people, do you consider yourself to have rather than have you been diagnosed with? Because
Yeah.
the tools to screen and like identify
Accessibility.
is not great, and the accessibility of actually getting a diagnosis are particularly, there's like unique barriers to diagnosis for transgender diverse people and LGBTIQA plus people broadly that don't exist in other populations. And those things definitely have a big impact on eating, exercise, neurodivergence with trans identity and experience. Like there's these overlaps in the middle that make it extra complex as well, just to like throw onto the pile of things that can already be making it challenging.
Yeah. There's a it's There's so many questions I want to ask because it honestly, the intersectionalities of all of these different components in terms of being able to access care, it's like quite overwhelming because I mean,
Mm,
first of all, most like a lot of trans and gender diverse folk have to almost justify their existence or identity half the time, which is, a problem. When, especially when you're talking to a medical professional who's just like, why can't you just believe what your patient's telling you? But and then there's also the limitations that comes when a lot with neurodiverse folk who again have to justify the existence of this, not condition, what's the word?
my brain works a different way.
Yeah, that's exactly. But
I have a different operating system.
exactly. I mean, like hearing you say all of this, there's I don't ask myself why eating disorders are at a higher rate for trans and gender diverse folk. I ask myself why not. Like everything makes sense. Like, well, yeah, because eating disorders often are a coping mechanism to deal with a whole bunch of other things, as well as adding societal stress, as well as adding in like beauty standards because they affect everybody, as well as things like gender dysphoria. It's a melting pot of this is exactly what this is a huge problem, and
Mm,
it doesn't like I'm so glad that the research is coming out now, but it's like it makes perfect sense, and you don't have it's not a stretch to understand why this is happening and why it's happening in such the huge numbers that we're seeing. It's it's overwhelming. So,
Yeah.
and this is just someone who's just witnessing it, not someone who's experiencing it. So it's just it's a lot to take in. But I guess the main question, one of the questions I wanted to ask, because I'm curious to know the actual role that it plays. What is gender dysphoria and what role does that play in eating disorders? Because I know, like, we know what gender dysphoria is, but I need that very, I need the soundbite from someone who is far more learned on it than I am.
So, gender dysphoria is, we usually would say, gender dysphoria is technically the diagnosis in the DSM in order to access gender affirming medical care for transgender diverse people, but it's generally not used in community to mean the same thing. It is an experience that not all transgender diverse people have, um, but many of us do. And we define it in community to kind of describe the distress or the disconnect that comes from one's body and sense of self not matching. And that is the physical body when we are looking at ourselves and existing in our own bodies, but also the way other people are perceiving us and gendering us based upon our appearance and body. And we tend to talk about it as a distress or disconnect because also there is often this dissociation from our bodies, this sense of disconnect that's not necessarily like the media portrayal of wanting to punch the mirror. It's often just kind of feeling like you're not really present in the way that most other people feel present in their bodies. It's often hugely taxing. There is, for many people, impairment of their day to day lives and function, poor mental health, and yeah, there's some recent research to show that all of the components of having to deal with gender dysphoria take up huge amounts of executive functioning, and therefore it impairs your ability to do other things and exist in the world. Um, the kind of opposite of gender dysphoria is gender euphoria, which we tend to like to talk about as the focus instead, because that's not a diagnostic thing in psychology. It's more a community experience and just general trans experience. That it's not all about alleviating distress. It's also about being comfortable and feeling good. And there is a very pleasant sparks joy feeling from feeling comfortable and present in your body that many of us are trying to reach. That's not everything being perfect, because no one ever feels this sense of being perfect in their body or everything being wonderful always and forever. That's just the nature of body image and being human. But it is a joy to feel good and comfortable, if you've not always felt that way. And yeah, as you can imagine, because it's related to body and body image and social perception, gender dysphoria and sort of that lack of congruence between body identity and the way people perceive you can be a huge contributor to people's eating, exercise behaviors in a range of ways. I think some of the key ones are, and it's always complicated to talk about this because we don't want to be encouraging the behaviors, but using disordered eating and exercise behaviors to manage one's gender dysphoria, unfortunately, is often very effective. And some of the ways that we see this is trans and gender diverse young people suppressing their puberty because they can't access puberty blocking medications. And as many people will know from sort of the idea of the quote unquote female athlete triad and things like that, if a person's weight is too low and their body is sort of in a state of shutdown, puberty will be delayed or suppressed. Things like menstruation will likely go away, and those things that are distressing are therefore not a concern anymore. But there's a huge toll on the person's body and psyche that comes from that. Being in a smaller body or a larger body, depending on the behaviors involved, can make someone appear to others more as the gender that they truly are. And so there's often this feedback loop of people perceiving you correctly, and therefore that reinforces the behaviors. And yeah, unfortunately, like so much of the way that we experience the world in our bodies, in our society around gender, is about body fat distribution and where we carry it on our body in gendered ways. And so manipulating that can, in some people, mean that their hips look smaller or that they might have more breast tissue than they do. And that can feel very, very affirming for someone if they're not able to access the kinds of care that they need in order to, actually have that affirmed in a healthy and safe way.
Absolutely.
Yeah, it seems that the main core part of treating an eating disorder has to come alongside accessing gender affirming care. And while all trans people deserve the right and deserve the right to have accessible gender affirming care, it seems like that's even more necessary when you're coming to treating an eating disorder. Would you agree with that?
Absolutely. It is, if someone's eating disorder is related to something like suppressing their periods, then treating that in the way that you would treat someone typically, which is, therapy to become more comfortable with this idea of menstruating and that being normal and healthy, is not going to be helpful. You have to be getting creative in your sort of specialized, individualized care about what can we do to healthily meet these needs that you are meeting through your eating disorder.
Absolutely.
And that's just not the way treatment currently works. And I think it's very easy for people to get confused between gender dysphoria and body dysmorphia and where they intersect. Because they're often treated as the same or very similar things when they are very distinct experiences.
Yeah. So we may as well go down that line. Could you maybe talk to us a little bit about the differences between the two so it's very clear for people?
Yeah,
sure. So gender dysphoria, distress or disconnect related to one's body in terms of gender and their gender identity, their sense of self not matching. And that is an accurate perception of one's body. To say I have breast tissue that shouldn't be there because having it is not aligned with the norms of being this gender is not it's not a distortion. It is true. A person with body dysmorphia has a distorted perception of their body image and perceives flaws or body parts or things to be there that are not, or they are significantly inflating or deflating the reality of that. So thinking about like the classic but not very true image that's used to describe an eating disorder, where it's like someone in a larger body looking in a mirror and seeing a smaller body or vice versa, we think that's like kind of the visualization of what body dysmorphia might look like. It can also be, someone having a facial feature like a nose that they think is much bigger than it really is. It's distorted. It's not true to that person. And that's the treatment for body dysmorphia is around helping someone to accurately perceive themselves. Whereas gender dysphoria, that their perception is already accurate, and trying to get someone to accept their body as it is when they experience gender dysphoria. There's no evidence to support that works, and in fact, it's not a good idea. And that's the psychological understanding of the differences. But we have actually seen some really cool brain imaging studies where they've induced dysphoria and dysmorphia in people and scanned which bits of the brain light up and how to actually, yeah. Whilst they're separate studies, I've looked at them both and gone, okay, the bits lighting up are different and the patterns are different.
Incredible.
In the case of some of the studies I've seen so far, when you look at them, gender dysphoria, the brain is going really fast. It's hyperactivated in some of the areas that do visual processing. In body dysmorphia, the bits of the brain that are doing the visual processing are hypoactive. They're basically going too slow. And so the sort of theory at the moment is that a person with gender dysphoria is hyper aware of body parts and perception and things that are not correct for them. Whereas a person with body dysmorphia, it's like their brain isn't processing the accurate image fast enough, and they're filling in with their own values and attitudes about themselves that gap. Yeah. And it's influencing the way that their visual processing is actually interpreting that information.
That just explains it so perfectly.
Yeah.
As a visual person, that explains it absolutely perfectly.
Yeah.
And what kept coming up for me was just okay, so let's talk about the treatment, because I feel like you've already touched on, and it just kept coming up for me because I'm just well, this is not the system that we are treating in. This is not how things are done. So I just wanted to talk about that because that's not how eating disorders are treated. Typically, it should be, but it's not. The system that we have currently does not treat eating disorders for trans and, gender diverse folk. They just don't. So I wanted to talk about that with you a little bit because yeah.
So apart from everything, what needs to change about the way we treat eating disorders in trans and gender diverse folk?
Please. Yeah.
You're ready for the rant.
The floor is yours. Go, please, because I just think of myself as a practitioner, and you're not taught anything about this, but also majority of I already have so many gripes about the system, but it's just, yeah. Anyway, floor is yours. Please go.
So I will try to be brief, but I think probably worth knowing that myself and some of my amazing colleagues who are also gender diverse folks with lived experience submitted a very long submission to the Australian Human Rights Commission about the harms of eating disorder treatment for transgender diverse people. So that's available and goes into a lot of detail and includes a lot of sort of lived experience quotes from Australian folks about how their treatment harmed them. But I guess I'll start with just sort of the sort of broad statistical overview of what we know, and then some of the kind of key issues that keep coming up. So in that sort of August timeframe included data, we found that a very, very small proportion of people who had been diagnosed with eating disorder ever accessed treatment for it. It was 17.11% of the people with a diagnosis ever accessed treatment.
My God.
If you want to sort of flip that, about 83% of people who got a diagnosis never went on to get treated.
Which is horrifying, but sadly makes sense, because I kind of think of it and where would they have access to how would they have accessed adequate treatment?
Yeah. And we asked people who had accessed some kind of treatment, did you find it helpful? And we used a Likert scale from, very unhelpful to very helpful, neutral in the middle. And anything that was above neutral, even a little bit helpful, we classed as helpful for the sake of sort of simplifying it down. And 2/3 of people said their treatment was not at all helpful. So if we kind of look at even neutral, if we include that as helpful, 2/3 said that it was actively unhelpful.
Wow.
Which is huge. And that's sort of consistent across all of the research that we see that has come out in various countries, is that the way that we broadly treat eating disorders is not only unhelpful, but actively harmful. And we hear all the time in conversations with trans people and in research where we talk to people who've experienced these things that they often wish they'd never gone to treatment because it made them infinitely worse than they started off. And some of the common stuff that comes up that's just sort of bad inclusive practice is things like misgendering people, invalidating trans identities, and worsening their dysphoria and distress. And if the source of their eating disorder is around dysphoria and distress with their body, it's just going to elevate it more. There's that loss of bodily autonomy, which is very important broadly for everyone. And if you are rupturing that therapeutic relationship by kind of constantly misgendering a trans person who's being treated, then you're not going to be able to get to meaningfully understand each other. The things we hear about are things like in my master's study, I had a participant who just sort of sits in my brain all the time, who talked about being so unwell that they needed to be put on bed rest and were not allowed to get out of bed for about a week. And the mental health nurse who was in charge of looking after them didn't believe that trans people were real and spent the whole time telling them that. And they were in a position where
didn't get away.
That you can't leave that situation. And I think that's something that is important when we think about like hospital-based care, is that you are captive in that situation. You can't just say, I'm uncomfortable and you are being disrespectful and I want to leave.
You're at their mercy.
Yeah. And that's terrible. Also broadly, like at a systemic level, most hospitals don't allow for like an alias or a different name from your legal name on the system. And that means that every changeover of staff, you're getting your name confused again and having to correct people. And the exhaustion of that when you're already so unwell is huge. Then there's the gaslighting component that comes in a lot, which is often this idea that like being trans is a component of an eating disorder. It's an offshoot of dysmorphia and it's something that needs to be fixed or treated. Or if someone's questioning their gender, being told that, that's just the eating disorder voice trying to find a new way to access and like maintain itself there. And all of those kinds of just like basic experiences of the invalidation and the sort of, transphobia, sort of systemic transphobia in the system mean people who do access treatment don't come back. And if they do come back, they often won't disclose that they're trans if they can avoid it, which means some of the root things that are underlying there are not being addressed.
Never actually treated, because and it's interesting you say that, like acting as if it's a component of their eating disorder, when really their eating disorder is there because of all of this, trying to figure all of this stuff out. And it's like, it's just been treated the wrong way around.
Yeah, and I think there's a really interesting model that is kind of sitting in my head from the various studies I've had to read recently, where the connection between dysphoria and minority stress is quite complicated. So minority stress broadly is sort of the way we understand and explain why the rates of mental health concerns are higher in marginalized populations. It's not that there's something inherently wrong with being trans or that being trans is a mental illness in itself. It's experiencing chronic discrimination leads to levels 100%. Of distress.
Depression.
So, we talk about sort of the external factors, like the way that people experience misgendering and family rejection and things like that. And if that's happening constantly, then there's also that like internalized transphobia that comes from that. Thinking that being trans is bad, thinking about your body even more negatively. And that sort of internalized transphobia is associated with much more negative body image on top of the dysphoria that's already there, which is then, kind of connecting to those eating behaviors that alleviate that dysphoria and help you cope with the stressors all at once. And it sort of loops back around that maybe those external stressors become reduced because you're passing more, you are more sort of protected from that abuse, which it's very tricky. Yeah.
You posted a tweet on April 30th this year, 2024, that said, quote, current eating disorder treatment models, when applied uncritically to trans people, are conversion practices, aka conversion therapy, end quote. Having heard you talk about all of that, I can totally see why.
Oh, yeah.
Why it's considered. It's basically a conversion therapy by saying you're not, trans people don't exist, or, oh, it's all in your head, or no, your eating disorder is just trying to trick you. When you said, when I read that, I was thinking, oh, maybe we should unpack that.
I think you kind of have.
You totally have. And it's, when you put it in plain terms like that, it 100% has the same sort of
100%
markers,
tone.
right, of what conversion therapy, quote unquote, actually is by just saying, oh no, this is an illness, we've got to cure this from you. It is barbaric.
Or having a mental health nurse sit in your room and tell you that it's not real.
Yeah. It's something I'm working on a paper about at the moment, is sort of conversion practices in eating disorder treatment, not just of trans folks, but also people who have a diverse sexuality as well, that we hear about this happening. But yeah, I guess it's not just the individual treatment of staff, it's actually like the models of care we use and the sort of psychotherapies that we use are inherently built in a way that if you apply them to trans people is conversion practices.
Well, I'm just thinking of CBT. How does CBT align with this?
Yeah, so I guess it's probably useful to define conversion practices and then maybe like delve a little bit into some of the therapies where this is kind of very, as examples of like how this is functioning.
Yeah.
So
yes, please.
Conversion practices, in the sort of accepted definition, are any practice, therapy, treatment that
therapy in inverted quotes.
Yeah, trying to change or suppress or even like eliminate a person's sexual orientation or their gender identity, gender diversity. We use the term that's used in like general social life is often conversion therapy, but in sort of most inclusive and like accepted terminology, we say conversion practices because therapy implies that it is therapeutic, and we totally reject that idea.
Not.
So if we think about that in the context of eating disorder treatment, anytime that someone is being told to change, suppress, or eliminate their transness, that's meeting the definition of conversion practices. And at the core of pretty much all of the treatment that is accepted for eating disorders in sort of psychotherapy and psychology, we've got this root idea of body acceptance, that we are trying to get someone to accept their body and stop trying to change it through their disordered eating behaviors. And that makes sense in the general population, that you're right, for a cis person who is experiencing body dysmorphia, body acceptance, body neutrality, body positivity, those kind of things are going to be beneficial. But if we're thinking about a gender diverse person who their gender dysphoria is the core or a component of their behavior, telling them to accept their body as it is in its current form is incredibly harmful. And so we see things like, I know in Perth, in Western Australia, where I am, there is very limited public treatment available, but the public treatment that is available is CBTE based. And a lot of that ends up being like somatic work, mirror exposure. And I just hear so many experiences of people who are gender diverse saying, mirror exposure was the most torturous thing that I've ever experienced in my life, because you're being asked to stand in front of a mirror and feel the distress of looking at your body. And for a cisgender person with body dysmorphia, that is evidence-based. It helps that person to more accurately perceive their body, and like it reduces the distortion. But for a gender diverse person, you're just creating dysphoria that will not be reduced over time by doing it.
Yeah.
They are critically aware of the
Exasperating
way
it.
that their body
Yeah.
is and exists. That's part of what
It's
causes
just
that distress.
traumatic.
Oh God.
And we hear these like people saying things in treatment to trans people like, I understand that you feel bad about having breasts, but that's just a normal part of being a woman. And they're trying to frame it in this way
Oh
of like, convincing this person that they are in fact not the gender that they authentically are, but that their presumed sex and the gender that's associated with that is the truth for them, and that they need to learn to accept that, which is
no.
Yeah.
conversion practices, in a nutshell, really. And we see that in pretty much every form of psychotherapy that we use, whether it's CBT or DBT or any of those ones. There is some component in that of the core idea being that your body is not the problem, and accepting your body is the aim. And in some instances, like there may be a component of body dysmorphia as well in a trans person. Not everything is always dysphoria, but it's being very intentional in targeting those things as distortions, not the entire person's gender experience or gender identity as a distortion or a problem. Yeah, and then I guess the more on the nose one I'm starting to find in some of our research is that conversion practices are a huge vulnerability in family-based treatment, um,
Mm-hmm.
and that's not necessarily the clinicians kind of using that body acceptance approach to say you need to be fixed or changed, but rather when the whole idea of family-based treatment is that you are giving control for that young person over to their caregivers,
Mm-hmm.
in theory
Oh.
only of their eating behaviors, but often an unsupportive family hears you are now in control of your child's behavior and can feel that that is a license to also control their gender expression, their access to gender affirming care, who they can see, what pronouns and name they can use, and things like that. And we've heard a couple of experiences in one of my studies that were so close to publishing, of of family-based treatment, FBT, being weaponized to essentially detransition young people, to say, oh, I'm in control now of what you can and can't do, which means you're not allowed to transition
Oh.
anymore. You're not allowed to see any trans people. You are completely cut off from
Oh, that makes me sick.
accessing anything related to trans people. And that's terrible. And, it's the so-called gold standard if someone's under a certain age is that you go straight to
Mm-hmm.
FBT.
You go to
Yeah.
FBT, and it's all in the parents' hands now and the team's
And the
hands.
assumption
You don't
there
have to
is,
worry about it anymore.
yeah, the assumption there is that all families are going to be supportive and safe and caring. And that's broader than just trans people. The assumption there is that a family is not abusive or harmful at all.
And that screening's not done.
And I had a bit of a look, but there is, to my knowledge, not a single study showing that FBT is effective for trans young people. In fact, we don't have any studies at all that any of the existing treatment models are effective for trans people. We got one case study in total that even mentions what kind of therapy was used, that actually discusses its efficacy at all. But essentially, no evidence to say that any of them are working, but lots of evidence to suggest that they are not working, and that if anything, they are causing immense and irreparable harm by making people feel like they are broken, which is kind of what conversion practices do at their core, is make people feel that they are broken and need changing. We add the neurodivergence component, and feeling like your behavior, your sensory needs and things like that are also broken and need to be kind of forced through. You're just adding layers on layers. feeling that defectiveness.
Yeah.
Yeah. I have so many things that are coming up, and like I definitely want to ask you about, like, in, I guess, what you have found could be helpful, like what treatments maybe would be helpful. But I just wanted to ask around just quickly, because if folk are going into the system, and it's, harming them, and they're coming out of the system, what came into my head was just like how much blood is on our hands here. If I'm just thinking about, like, if they are really medically unwell and they're not receiving treatment and they're leaving and they're not going back, like, how many folk are losing their lives from this because they're not getting treatment? Or how many folk are then, maybe they are stuck into the system, and so then they're being labeled with particular labels, and then perhaps that goes into a seed diagnosis or whatever, seed being severe and enduring. So then they're stuck in that cycle, and then it's like, well, you're never going to get better. Like, I'm just curious around that sort of thing to begin with, and then I want to jump into what might be helpful.
Yeah.
Yeah, I think seed is an interesting one. My current perspective, which is not as evidence-based as some of the other stuff that I've done, because I don't think there's enough data to really say, but I'm not convinced that anyone is sort of treatment resistant or severe and enduring
Agree.
in the sense that they
I'd agree.
cannot be helped.
Yeah.
My feeling.
We're talking to someone who, Callie, who was diagnosed with just that, and lo and behold, it looks like she's better now. So
Yeah.
I think it's a
That works.
strange way to do it, is to say, the individual person is the problem because they are not improving, rather than kind of interrogating what about treatment isn't working for this person. And such a huge proportion of cisgender women who have anorexia diagnoses who are not improving with treatment, who have that SEED diagnosis or the equivalent of in research, when you screen them for autism, they have really high rates of, like, the scores are in the autism range, which makes it a curiosity of, there is many ways that treatment is not effective for neurodivergent people and autistic people broadly. If we force someone to eat with the meal plan in a way that is foods that are unbearable from a sensory perspective, that's not going to make that person better. Doing that sensory profiling and learning what foods are and aren't right is what works. And I find, compared to other mental health concerns where people are treated as like a collaborator in their own care and working to improve, it's so didactic in eating disorders, where it's like, you don't know what's best for you, but I, as the clinician, do, and you have to do what I tell you. And there's such a loss of autonomy that comes from that.
It's horrific.
That's why I find, like, I think dietitians are can be some of the most important people in this process, if they are, doing their job amazingly well, which so many of them
I was going to say,
It's creating collaborative and creative solutions to work around problems and accommodate, rather than necessarily kind of brute forcing through things. Some people might, always have certain difficulties with a particular food, or a particular food group or sensory texture, and the solution sometimes is to go, okay, well then how do we work around that, rather than trying to keep pushing up against it.
no, push through it, get over it. Exposure. It's like, no.
I think it's okay. It's
I just want to say that, like, like, why force them? A big deal. Like,
they're never going to eat these types of foods. So why are you forcing them to have it in treatment? It makes no sense.
I think we need to reframe what recovery means in some ways. What does it mean to be severe and enduring is also, like, me and my colleagues used to talk about, like, the idea of, like, a neuronormative idea of what recovery and healthy eating looks like. Is, I'm never going to be someone who eats a million fruits and vegetables and heaps of protein, but my current eating and health is good. It is good in a way that works for me, and my basic needs are met. But if you compare me to the standard that is set in a neuronormative way, then I might not meet that. Yeah, it's challenging. But I think, I like of the existing treatment models that we use. I think SSCM, Specialist Supportive Clinical Management, is the one that
Yes.
I'm like, that one is okay.
Agree. Yeah.
Because it's like, it's much more of that collaborative approach. It's thinking about what that person needs and working with them in that, instead of telling people what to do. And it's about being more creative in understanding what function is this behavior serving and how do we get that need met in another way so that that behavior can
And it's
fall
covered
away.
under the EDP too.
It is, yes, which is great.
Which is incredible because I think people think only CBTE is covered under the EDP, but SSCM is also covered under the EDP.
And I can see so far in my sort of planning around what good treatment for trans people might look like is things like doing that discussion with that person about what are these behaviors doing for you that is helpful, and then getting creative with sort of the case management around, okay, you got distress around menstruation, can we put you on, I think it's called like mexotramic acid that helps reduce bleeding, or a contraceptive that will stop this for you, or referral to get a hysterectomy that you have always wanted. It's providing that, like, rather than dragging someone by the hand, it's like holding their hand and walking them through that process, and it's often much more practical things.
Yeah.
Which is what medical care should be.
Yeah. And if someone's experiencing immense minority stress because they're having complete rejection from all sides in their life, forcing them to, address address weight gain in that exact time frame might not be the most appropriate thing. That's just adding to the pile. If that's the only sense of control someone has, then sometimes it's about improving that nutrition without necessarily the focus on immediate urgent weight gain, depending on where they're at. And a lot of dietitians are doing awesome work in that, in terms of like, all right now weight gain is not an option, but can we improve your vitals, your heart health, things like that, by getting creative with the kinds of things you're eating or adding supplements, things like that.
Harm reduction.
Just kind of throwing away the rule book of what we are supposed to do and actually questioning what's right for that person. And I think that's hard for most people in eating disorder treatment land, because so much of it is like rigid. We're going to do CBTE and it's 10 to 20 sessions and each session does these things. But of course, something that's that structured isn't going to work for everybody, because people are individual and have different needs, different experiences.
And it might be like, maybe this bit doesn't work at this time either, and then I always find it so interesting. We're like, oh, well, that therapies didn't work for them. And it's like, oh, maybe it doesn't work just now. Like, can it be revisited down the track when they're actually ready for that component, rather than forcing it upon them right now? I always find that really interesting.
Yeah, I think from the neurodivergent perspective, as well, that it should really be like a ongoing part of treatment is that screening. And how many people, how many autistic women are experiencing like ongoing struggles with anorexia nervosa or another eating disorder, who just don't know that they are neurodivergent and therefore have the accommodations they need. Like, I find a lot of people, their eating behavior is restrictive to manage the sensory distress of like loud noise and things, because that becomes dulled when your cognitive sort of function is impaired to an extent. I think it's a few things.
It makes sense.
It's like we need to integrate that gender affirming care, be more person centered, think about the actual function of the behaviors rather than diving immediately into fix, weight restore, etc. And yeah, it's I think a lot more about accommodation than it is about fix in many instances, but we are really focused on fix. And trying to meet some kind of standard that is just
measurable,
impossible.
Right? It's like they can tick some boxes and say that I've done this, and and it's like, I think half the time, and it's a big gripe of mine, is like, it's actually not about the practitioners, and I think sometimes they forget that. It's like actually about the person that you're treating. It's actually not about you and what that's a huge gripe of mine. You see it so often, I think.
Yeah, it's a broader problem with evaluation as well. I think that our services are set up in a way where if you are the clinician, um, even for me when I was a case manager, it was, you need to have this many clients and they need to get better in this time frame so you can discharge them, so you can take on more clients. And the pressures that are put onto you as like the professional also mean that you're kind of put in a position where you either have to accept that you're not going to be meeting your quotas or deadlines of things that are supposed to help you make a living.
Yeah. Yeah.
But
Yeah.
those things are going to be potentially detrimental to the people that you're working with, who are the focus. It's not about me or about my stats or numbers. It's about the like actual quality of lives of the people that I'm supposed to be helping. And I find a lot of people get to that burnout point where people suddenly start becoming seen as too hard or too difficult, or like they're going to take too long to get
100%.
better. And I think we need to be reducing, like ideally we would have smaller client loads and we would have different measures of what it looks like for that person to be improving. And even like things like the K10 and the scales we use to measure that improvement often don't work very well for certain groups of people. Like the K10 doesn't go so well for neurodivergent people because it automatically picks up things like jitteriness that are part of ADHD and goes, their anxiety's high.
Your anxieties. I always score so high in like anxiety type tests, but great in depression.
Yeah.
In the areas of depression, and I'm like, I'm actually not an anxious person. I have ADHD. Like
exactly, and so it often means that people with ADHD might not be seen as getting better fast enough in some kinds of treatment because their scores aren't changing in the way that one would expect from a neurotypical person as well. So I think there's a lot of like, who are these measures made for and who do they not work for very well, and how do we change them or use different ones, or just be mindful of the limitations of all the kinds of things that we're doing.
we even think of like the eating disorder questionnaire, right? Like the limitations around them. There's many limitations, but like
many.
it's based. I was going to say like I don't know where to start, but like let's just choose the most obvious one. It's based around weight and shape.
Yeah.
Yes.
And that's it. And it's and then that kind of determines whether you can actually get an EDP, whether you can, it's wild.
Yes, getting an EDP is extra complex for trans people for sure.
Yeah.
So many
Yeah.
layers there. I facilitated a journal club session yesterday for the Australian Eating Disorder Research and Translation Centre on the EDQS and its validation in trans people and sort of the limitations of its use for trans folks, and that was fantastically useful discussion. But several of the measures have been validated for use in transgender diverse people, but they are questionable as to whether they are, whether they are useful despite the fact that they are validated. There's a lot of limitations where they might be inflating or deflating the severity because of the fact that they just weren't designed for us. They weren't designed with us in mind, and therefore they're not, tailored to the contributors and the behaviors that are the common ones in our community.
One question I do want to ask, if you can speak directly to eating disorder, if you can speak directly to transgender and gender diverse folk who are living with eating disorders right now. I know that we've just kind of dunked on the entire system, which is very worthy of dunking, on how terrible it is. But what advice would you give to those who are currently trying to navigate the system? What advice could you give them to help advocate for themselves, to ensure that they can access some kind of helpful treatment, something that's helpful, and how can they navigate getting some sort of help without, in a harm reductive kind of way?
It is definitely a difficult system to navigate, and I don't want to sort of like undersell the fact that it really is a minefield. I've experienced good clinicians, bad clinicians, but I don't want to suggest that there is no hope or there is no good treatment out there. There are some fantastic clinicians working in Australia, um, including a bunch of clinicians who are trans people with lived experience of eating disorders who get it from that personal perspective and have the clinical and professional skills to help. There are people who are working outside of the accepted, treatment styles that we talked about that are harmful, or they've found ways to adapt them so that they are meeting the needs of their trans clients. And yeah, it's hard to find those people necessarily. It can take a bit of extra work, but I think there are like Eating Disorders Victoria has like an LGBTIQA plus peer support group specifically. There are organizations in other countries like Fed Up, which is fighting eating disorders in underserved populations, which focuses mostly on trans and intersex people. That has like a scorecard for what a good service looks like. And whilst they have a list of US services and where they fit on that scale, I'm hoping that we can build sort of a similar system here of identifying who's doing great care and who's not. And I think if you can, finding someone who can help advocate on your behalf so that you don't have to be the constant corrector, get care earlier rather than later is preferable, because the people who are best in this space tend to be psychs in private practice, not in a hospital setting, and dietitians who are, working in dietetic sort of services rather than in a hospital setting. And my personal advice is don't be afraid of telehealth. My team of sort of clinicians that support me, I don't think a single one of them lives in Perth or even on sort of this side of the country. I went looking for people who were gender diverse and had lived experience and were clinicians, and they are a quick Google away, really. It's just finding them can be a bit of work, which is frustrating. But ideally, we can collate that information and put it together. And I get Instagram messages all the time and Facebook messages asking, "Can you recommend someone to see?" And usually there is someone who has open books who is going to be a good fit out there. So I guess don't be afraid to reach out to me or some of the other people in this space who are talking about this openly. And I think it's easy to feel like recovery is not possible based on the information that we've said today. But what we're doing by identifying the issues with treatment as it currently stands is also figuring out what's missing from that. A lot of what's missing from that is that if a person's body is the issue in terms of dysphoria, then gender affirming care can often really, really help. And so trying to access that, if that's something that's of importance to you, trying to figure out for yourself, even like obviously self-treatment is not for everyone, but I would encourage folks listening to reflect on what function are my eating disorder behaviors or the eating disorder as a whole serving for me? Am I coping with the distress of like transphobia in society? Are there parts of my body that I'm trying to minimize or emphasize or change? And what other ways are there for me to get those needs met that might not be as harmful to my body? Do I need to talk to someone more about how hard it is to be a trans person in the world and experience transphobia? Are there peer support groups that I can access that will help me to feel less alone in that? If I can identify certain body parts or components that are particularly distressing, are there ways that I can use a chest binder to reduce that or change the clothing that I'm wearing to de-emphasize those parts of my body? Are there surgical or other like medical interventions that can help that I can be working towards pursuing? There are ways to work through these things that aren't going to be, sources of lasting physical and mental damage in the way that an eating disorder is. And there are so many people out there who are going through the same thing that can be really helpful to talk to.
Yeah. That's incredible.
Yeah, thank you so much for that. We often talk on this podcast, and we talked about it, I think yesterday when we were recording our quasi-recovery episode we believe that anyone can recover from an eating disorder and all eating disorders are treatable. However, not everyone can recover because they don't have access to appropriate individualized care that validates the illness that the person is living with. And I think that's what is key here, is that accessing the right treatment is integral to getting better. And I know that sometimes it's just like, well, I can't access it, so am I just going to be destined forever? It's like, it's such a tricky system to navigate that so many people get left behind. And that's why we need, and by sharing lived experience and by advocating for people who don't have the same access as a lot of other people, that's how we can create change. And if we just don't shut up about it, maybe someone will pay attention.
And I never shut up about it.
Good.
Please don't.
Yeah, my PhD is going to be another 3-ish years of working towards publishing a bunch of stuff on this area and ending up hopefully with some guidelines at the end that are going to say, here's exactly what you should do. And then, people listening who have got lived experience and are looking to get better treatment, you can walk in with a copy of it and be like, you need to do this.
I was going to say,
exactly this. And if you don't do this, then I'm walking to someone else and they can have my money or the Medicare system's money. And you're going to lose a lot of care from that. Ideally, I'm hoping that if I can find a postdoc to do after that, because I would love to keep doing this. My ideal postdoc at the moment is to start off with what we call a clinical audit, where basically after the guidelines are published, we basically interrogate the services to see if they're applying them or not, and we can kind of rank them and identify who is good, who is not, and be quite public about who you should go to and who you should not go to.
Yeah, that's incredible.
Yeah. I cannot wait for that.
Neither can I. Thank you so much.
I want to shift gears just a little bit before we round up here. Mainly because we chatted about this yesterday, Kai, in our little DMs. And it was like, oh, that's interesting. And I know that you're big on TikTok. I don't understand it because I think
I downloaded TikTok like 2 weeks ago because a client forced me to. No, she didn't force me to, but.
Yeah, I don't quite understand it. But you were talking about something very interesting about how TikTok impacts people with eating disorders as a whole, but especially for those who are gender diverse. Can you talk about that? Because it was very interesting what you were telling me about yesterday. And I'm like, hold that thought. I want to talk about this tomorrow.
Sure. There's some really interesting data that's coming out at the moment from Dr. Scott Griffiths, in particular, who's at the University of Melbourne. A lot of his work has historically been about men's body image and, for example, amazing study on how Grindr affects gay and bisexual and other MSM men who have sex with men's body image.
Oh my God, which is a minefield.
Chef's kiss. Amazing research. Everything that he publishes, just blows my mind every time. At the moment, he's really doing a lot of research on TikTok and its effect on body image and people's eating behaviors, eating disorders. And some of the really early data that's coming out from that is that it doesn't seem to matter what you look at on TikTok on purpose. You're going to get eating disorder content popping up no matter what. The algorithm prioritizes showing people that content because it's about how much time you spend on the app is how they make money. And it doesn't matter whether it's negative or positive content that causes you to spend more time on the app. But
Yeah,
some of
right.
the early work that is happening from that is that they showed um, healthy controls and people with eating disorders TikTok and saw sort of like who was getting more eating disorder content. Um, and the people who were already experiencing an eating disorder were being platformed increasing and increasing quantities of more and more awful eating disorder content. Because if that's what is keeping people engaged online with the platform, then it doesn't seem to matter whether that's helpful or not. Um, Based on a second study that he did, which was really cool, was creating brand new TikTok accounts and seeing how long it took for eating disorder content to come up by just flipping through the main page.
Wow.
And according to the little abstract in front of me, because I want to make sure I get it right, it took only 3 minutes after starting a new account to be delivered appearance oriented information or like videos. It delivered an
Wow.
average of 19 appearance oriented videos in the first 30 minutes, which is,
Oh my
yeah,
God.
it is
Ooh.
super fast to do it. And, the what I eat in a day videos and all those kind of things just are constant on the platform.
Wow.
It kind of reminded me of that Twitter account back when it was still called Twitter. It was called Tay. I can't remember. It wasn't Microsoft or someone did it. They created this like AI Twitter account, and it
Mm.
just learnt based off what people were feeding it. And it took 24 hours before Tay turned into a Nazi. It
Mm.
was,
Oh my God.
yeah, it was insane. It was just like, okay, so this is how easy it is to manipulate machine learning, and it just goes to show how much
Oh my
bias and
God.
discrimination is built into AI. But that is a whole other conversation we could be having.
Yeah. In terms of
Yeah,
like LGBTIQA plus people and trans people in TikTok, it's a bit of a strange line in that there's another researcher at the Telson Kids Institute with me whose PhD research is around LGBTI young people and TikTok, and their research so far has found that actually like TikTok use can be quite protective and helpful because if you don't know any queer people in real life, and you
yeah.
have access to a sense of community, the way the algorithm platforms you more and more queer content, the more you engage with it,
Mm.
the
Yeah. Okay.
more sort of accepted and sense of community you might develop from that, to like massively oversimplify the research. And so from that standpoint, it can be very useful for people. But the side kind of thing from that is that from a body image and eating disorder perspective, the people whose videos on TikTok tend to do well or who the algorithm platforms tend to have a particular body type or aesthetic. So there's some interesting stuff in the research around trans people that what it means to look non-binary is a really complex thing. So, we live in a society where there is men and women, and the majority of people don't sort of believe or understand or subscribe to the concept that there's middle ground in between. And so, to look like a non-binary person in a society that says there is no such thing, um, how does one look non-binary in a way that means people see you for who you are? And that is an impossible task. And so, in the trans community, it's like we've created out of necessity this shorthand look for what it means to be non-binary, and that often in alt-right jokes is like we have blue hair and we have this particular haircut, but in reality, a big component of that is the body shape and weight of the person. So we have this shorthand form for non-binary that is non-binary means androgynous, and androgynous means thin. And that is like the core issue that we see in some of the research coming out now is that for someone to be affirmed as a non-binary person in broader society and even in queer spaces, thinness is a core component of that. And it's something I think
Yeah.
about a lot in my
Okay.
life because I have kind of, you can look at all my family. We are all built the same. We are all just built tiny, and we cannot build muscle no matter how
Yeah.
hard we try. But I have I kind of inherently meet the stereotype without necessarily meaning to, and it's never been something I've thought about too much until I started dating my current partner, who is not a part of the trans community, and showed a photo to one of his friends who was a cisgender heterosexual person of me without providing really much detail about my gender or who I am. And that person immediately said, are they a they based on my appearance? And when asked, what made you say that? They went, oh, like androgynous, skinny. So it's bizarre to me how much, it's trickled out into like general knowledge now that what it means to be non-binary is to be thin. And that's such a harmful idea in so many ways. But if you were to like go onto TikTok and search in non-binary and what the top videos are that are being, given the most attention, they tend to be the videos of people who are very, very thin. And often people who are concerningly and distressingly thin, who are quite open about their own struggles with eating disorders, but they are the standard that is being set. And a lot of the videos that you see of like non-binary outfits are videos that are, if you look at them with a critical lens, they are videos of body checking. That's often what the top videos of non-binary people are. It's not affirming content about who you are. And same thing with like trans men content is often all about compulsive exercise and being muscular and fitting the stereotypes of what it means to be a man. There's a lot of content that is about looking the right way, either explicitly or just sort of like through osmosis of seeing all of this stuff about what you should look like, that can be super harmful.
Gosh, my gosh. And if you're on TikTok and kind of like searching for that sense of community and that's sort of the content that's coming up for you, then that's kind of like, that's the community you're getting, right? And so you're getting this messaging that you're getting to belong to this community. I must.
Yeah. And I mean, the idea sometimes I think from people outside of the queer community is that everything's hunky-dory and we never have any issues or nothing is ever problematic. But the levels of sort of fat phobia and weight-based stigma are huge in the community, and there is heaps of trans folks who feel like they're already marginalized enough by being trans, and that existing in a larger body is just another layer of ways to be oppressed and marginalized that they don't want to experience, or that it's this intersectionality is a key thing there. It's so many layers of different ways that a person's body affects the way that they experience the world negatively or positively. And I think we're all constantly trying to like fight our internal battles of wanting to be authentic to ourselves and exist in a way that's comfortable and keeping ourselves safe and being seen by others for who we are.
And fitting in. Everyone wants to fit in. It's part of being human.
Yeah, even if you want to fit in by standing out.
Exactly right.
Yeah, it's kind of something I often find funny is like people will come out and they will change their appearance. They'll get the colorful hair, and it's like, oh, I'm different, like everyone else in my community.
I was going to say, yeah.
Which is totally fair. It's a process of experimentation and finding what's authentic for you. And I don't mean to like
no, absolutely
put down anyone for experimenting with their expression. But I think it's often making sure that you're doing things from a place of personal authenticity rather than trying to feel pressure to meet a particular standard of what you should look like.
Yeah. Agree.
Oh, this is, I'm trying to keep conscious of not making this too long. So I will finish on our last question. And we always like to keep it, quite, light and happy. But I guess the question we want to ask is, what excites you the most about your research and what you're doing at the moment?
Oh, it's a bit of a balancing act because I feel a lot of sort of sadness and grief that this hasn't been done yet, that people are still struggling because there is still so far to go in our understanding and shifting treatment to actually meet our needs. And simultaneously, I feel very lucky and grateful to be able to contribute to that knowledge, and to be part of making those shifts. And I'm hopeful, I guess, like I try to think of it as if we'd done this research 20 years ago, it probably would have been done by a bunch of older school academics who maybe did not understand us in the way that people who are peers can. And so I'm trying to focus on doing research in this space that completely centers people with lived experience as much as is feasibly possible, to make sure that that is the group of people whose voices are heard, whose needs are met. And I think whilst I am doing a lot of like quantitative research where we're doing stats and things, my favorite bit is always doing those qualitative studies where we're interviewing people and we're taking their direct quotes and the things that they say and the often the horrendous experiences they've had and putting them in complete, block quotes into a paper that clinicians are going to read and realize, oh shit, I've made some horrible errors. And there's something very powerful and that I feel a lot of gratitude about, in being able to help by taking people's negative experiences and helping to make meaning from them and make change through them. There's got to be something very satisfying, hopefully, for people reading those papers who contributed to them to see the sort of, the professionalism aspect, although we shouldn't need it. When it becomes a peer-reviewed paper, it adds this sort of weight and trustworthiness that makes people listen in a way that maybe, yelling on a street corner about how frustrating this is, which I want to do all the time, isn't taken as seriously. It's this legitimacy that comes from it that I feel like I get to help translate things into this way that hopefully will make people listen.
Integral for things to change is how things change.
So,
absolutely.
I'm excited to keep doing this work, and I'm hoping to just kind of like zoom through it to just keep learning and learning. And every time that I think I've solved a problem, a new one pops up, and we'll just be in a constant state, hopefully, of treatment's never going to be perfect. So ideally, we'll get to a point where it is not terrible and instead is good or good enough to meet people's needs. And then I can spend the rest of my career tweaking little things and going, oh, that little bit isn't working, rather than kind of throw it away, start again.
Which it must feel like you're kind of doing at the moment.
It's a bit like whack-a-mole.
It is, yeah. So I guess the most exciting part of the research is that there is going to be, unlike some research where it feels very removed from actual human lives, the focus is so much on application and implementation and treatment actually being different for the lives of people who need it and who are struggling. So hopefully that is where it will end up.
Cannot wait. Cannot wait. Cannot wait.
Yeah, it's going to be, we'll be waiting. We cannot wait.
Not to rush you, but also.
I'm rushing myself. It's a side struggle of life, but PhDs are, it's not so much the academic work is not the hard bit. It's the budgeting from not having a proper career going at the moment. So the faster I get it done, the sooner I can buy, coffee at a coffee shop again.
Well, we look forward to it.
Yeah, this was an absolutely amazing chat. I feel like I've just been like sitting here just like as a sponge, just trying to absorb everything as we explore your mind palace. It's been such a pleasure to talk to you.
Absolutely.
Now, please tell everybody where they can find you. I know you're big on the TikTok, so plug that. Where else can people find you so that they can interact with you with all of the stuff that you're doing?
Yeah, I love to nerd out about this stuff, so I encourage questions or people to, if you want to access research that is paywalled, please let me know what kind of stuff you want access to, and I will send it to you.
Oh, I will.
Often there's some really interesting like anti-trans books and things that exist that I would not recommend buying and supporting the authors of, but some of those have some really interesting stuff in there about eating disorders and weaponizing them. Please email me and I will send you PDFs so that you do not have to pay for them.
Incredible.
Yeah, I love to talk about this stuff, so please do not feel scared to reach out. In terms of where, I do use TikTok a lot. My TikTok is, to me, my knowledge translation spot. So I recruit for various studies through that and also try to take journal articles on queer and trans topics that are typically paywalled and simplify them down into 30 seconds or less as best I can. My TikTok is called @FruityNerdCentral. It used to be @QueerNerdCentral, but TikTok has a problem with the word queer, which means my account was temporarily banned. My Instagram is @GenderQueerNightmare, which is an interesting combination of I never removed my personal TikTok. I just started posting more PhD things on it. So it's half professional, half personal mix. A lot of my research that's published and some of the sort of blogs and articles I've done around this topic, contact details, everything else is on my website, as well as sort of the trainings and workshops that I do around this stuff. That's all on KaiSchweizer.com, which is a very hard name to spell, but if you Google that, you can probably get like, don't worry. it'll be "do you mean?" and then it will fill it in for you.
Show notes, all the links will be there.
We'll put the links in there.
That'll save everyone a lot of nightmares.
Googling.
And you do training courses as well,
yes,
don't you?
Incredible.
It feels like a million years now. Basic LGBTIQA plus inclusion training, training on supporting autistic trans folks, and sort of mini lectures on the way that the co-occurrence of gender diversity and autism is weaponized, how we can sort of challenge that, because a lot of it is using terrible, old, and invalid research. And most of the time at the moment, it's doing my training on supporting transgender diverse folk with eating disorders that goes into a lot of the stuff that we talked about today, but more depth, more stats, more everything, and a lot more sort of activities about how we actually implement that knowledge into treatment.
Awesome.
I will be clicking on that in the show notes.
So if you're a clinician and would like more training on all of this, head to Kai's website, because it is an invaluable tool. And I think if a lot of clinicians might think, oh, I'm just one person, how can I change something? You absolutely can. You can have an impact on even if you're just treating your one patient or however many patients, you can have a massive impact on a person's recovery. And if you do a great job, people will refer their other friends to you. That's how it works. So
also, end of financial year is coming up, so spend the money and go and do it.
Yeah, expense that. Do it.
One clinician is a huge jump in the numbers, really, genuinely. Exactly. Like the people who are amazing in this space often are so busy that they just cannot take on any more clients. And so we just need to keep sort of building those numbers so that, in an ideal world, everyone would already know what to do and it would be go anywhere. But we use referral networks and pathways and community lists. And the more people we can add to those, the more people aren't waiting until it's too late to get care. So it makes a big difference.
Yeah.
Exactly right.
Absolutely.
Well, thank you so much, Kai. It has been an absolute pleasure. You have been an absolute joy to talk to. And I
feel incredibly privileged.
Oh, thank you.
It's
genuinely forever heartwarming to be able to talk about these things. It used to be such a resistance to even like considering this stuff with most clinicians and most folks, and it feels so wonderful to talk to people who have this shared passion for making sure people with eating disorders have a chance to have a meaningful recovery, and also just to prevent them from ever happening in the first place and preventing people from suffering unnecessarily. And so it always makes my little heart hurt with happiness.
Likewise.
Likewise. Perfectly said.
Yeah, 100% agree.
That's all for today's podcast. Thank you so much for listening. You can find us on Spotify, Apple Podcasts, Amazon Music, YouTube, or wherever you get your podcasts. And don't forget to subscribe so you don't miss an episode. You can follow us on Instagram at pavedwithgoldpod, send us an email at pavedwithgoldpod@gmail.com, or visit our website, pavedwithgoldpodcast.com. All of those links will be in the show notes, along with extra resources, as well as where you can find Kai. Go there right now. Click, 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 click. Until next time, stay safe, and we'll talk to you again soon. Bye.
Bye.
This podcast is general in nature and has not taken your personal circumstances or medical history into account. We are here to share our own experiences and the things that we have found helpful throughout our own personal recovery journeys. Please remember that each person's journey and circumstances are different, and not all of the information contained in this podcast may be relatable to you. It's important you consult your own GP or recovery team to seek out tailored advice before making any important decisions relating to your own health and recovery process. If you have found any of the content in this episode distressing, please contact your care team or a medical professional. If you or someone you know is in crisis and needs help now, please contact emergency services in your region immediately.